My name is Brandon Bergman. I'm Associate Director at the Recovery Research Institute. Thank you so much for joining our talk by Samuel Meisel. He'll be talking about caregiver involvement in adolescent substance use treatment. Before Dr. Meisel starts, I just have a few introductory slides from the Opioid Response Network. If you could make sure to just mute yourself, that would be much appreciated. So the SAMHSA-funded Opioid Response Network assists states, tribes, organizations, and individuals by providing the resources and technical assistance they need locally to address the opioid crisis and stimulant use. Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorders and stimulant use disorders. The Opioid Response Network provides local experienced consultants in prevention, treatment, and recovery to communities and organizations to help address this opioid crisis and stimulant use. The ORN, that's the acronym for the Opioid Response Network, accepts requests for education and training. Each state and territory has a designated team led by a regional technology transfer specialist who is an expert in implementing evidence-based practices. To contact the Opioid Response Network, all you need to do is visit www.opioidresponsenetwork.org or email orn@AAAP.org. This is just a little bit more information about the funding that has gone to support today's meeting. And the approach of the ORN is to build on existing efforts, enhance, refine, and fill in gaps when needed while avoiding duplication and not recreating the wheel. Its overall mission is to provide training and technical assistance via local experts to enhance prevention, treatment, especially medications like buprenorphine, naltrexone, and methadone, and recovery efforts across the country addressing state and local specific needs. And just a quick note about, before we get to today's talk, about our next talk, which will be on July 8th by Dr. Sarah Bagley of Boston Medical Center, who will be presenting on integrating overdose prevention and opioid use disorder treatment into primary care, pediatric primary care. Registration information will be coming soon, and everybody who's here today, you'll get information about that in your email. So I'm going to introduce today's speaker, Dr. Samuel Meisel. Dr. Meisel is a licensed clinical psychologist and an assistant professor in the Department of Psychological and Brain Sciences at Boston University. He received his PhD in clinical psychology from the University at Buffalo, the State University of New York, in 2020. He completed his pre-doctoral internship at Brown University. Dr. Meisel completed a 2-year NIAAA-funded F32 postdoctoral fellowship and then a 2-year NIAAA-funded K99 postdoctoral fellowship at E.P. Bradley Hospital and Brown University Center for Alcohol and Addiction Studies. He joined the Boston University faculty in 2024, where he directs the Substance Use Mechanisms, Motivations, and Interventions for Teens Lab, also called Summit. Dr. Meisel's research focuses on social relationships, such as peer and caregiver relationships, and how they interact with multiple levels of influence, for example, temperament, schools, and neighborhoods, to influence adolescent substance use initiation, escalation, treatment, and recovery. The overarching questions that guide his work include: 1, what are the developmental pathways leading adolescents to initiation, escalation, and recovery? 2, how do we leverage social relationships to improve adolescent substance use prevention and treatment efforts? And 3, what are the key ingredients of adolescent substance use prevention and treatment programs that lead to behavior change? And with that, I will pass it off to Dr. Meisel, who will talk today about caregiver involvement in adolescent substance use treatment. The floor is yours, Dr. Meisel.
Thank you, Dr. Bergman, for that introduction. I'm very excited to talk to you all today. And first off, I just want to acknowledge that I have no conflicts of interest to disclose. My work is funded by the National Institute on Alcohol Abuse and Alcoholism, as well as through NIDA R24 to the Partnership to End Addiction, their first program. And for today, what I hope to do is first just give a brief background on adolescent development and substance use, and then in a short period of time, convince y'all that caregiving is essential to adolescent substance use behaviors, both the initiation and escalation of use, as well as to recovery and treatment. And then the second half of my talk is really going to focus on concrete strategies and practices you can use to engage caregivers in treatment. Um, I always like in academic talks to walk away with at least like one practical skill or tool that I can use. So the hope is that for those of you who are providers in the behavioral healthcare workforce, you can leave with some strategies to actually implement in practice. And also, before I jump into my talk, I want to note that my use of the term caregiver is purposeful. Um, Many teens who show up to treatment show up with their biological parents, of course, but many show up with caregivers who are not their biological parents, grandparents, family members, foster parents. So I use the term caregivers to be inclusive of the diverse array of people who caretake for adolescents. So that's why I use that term throughout this talk. So first off, adolescent development. What do we need to know about adolescent development to understand substance use? Well, when I talk to people about adolescence, I like to say that adolescence is kind of like walking a tightrope. Why is it walking a tightrope? Well, on the one hand, a central developmental goal of adolescence is forming close connections with peers. We know that adolescents who fail to meet this developmental milestone not only are at increased risk for substance use, for mental health conditions in adolescence, but also in adulthood, and they're also at increased risk for early mortality and physical health conditions. So while forming close peer connections is vital during adolescence, where do risk-taking behaviors like substance use predominantly occur? In the peer context. So the tightrope that teens have to walk is how can they form close connections with their peers, but avoid risk behaviors that occur in the peer context. And parents play a central role in helping teens navigate this tightrope. Navigating this tightrope is hard, and one of the reasons why we know that is substance use is still quite prevalent amongst adolescents. This is NISDA data, and I just want to note for this talk today, there are many definitions of adolescence. When I'm talking about adolescence today, it's roughly 10 to 18. NISDA defines adolescents as 12 to 17-year-olds. But here, past month use in 2024 per NISDA data suggests that 6% of teens drank alcohol, used cannabis, and also used tobacco products or vape nicotine. Also, about 250,000 adolescents misused opioids as of 2024, and 2 million adolescents meet criteria for a substance use disorder. Again, I want to emphasize these are likely underestimates because with increasing age, rates of use increase. So if we include 18-year-olds, these numbers are even higher. And there is increasing robust data pointing to the developmental consequences of substance use. And I just want to pinpoint some of these, but I know most of the people in this audience are well aware of these risk factors. So early substance use, as well as levels of substance use during adolescence, are increasingly being implicated in altered brain development. And adolescence is a critical period for maturation of brain regions implicated in executive functioning, in the processing of social and affective information. And substances seem to alter these important brain regions that are developing during the teenage years. Also, there are strong associations between using substances during adolescence and the development of a substance use disorder in adulthood. Adolescent substance use is associated not only with the onset of mental health conditions, but also the worsening of existing mental health conditions, both during adolescence and into adulthood as well. Adolescent substance use is associated with increased mortality. That's both a product of many substances are implicated in things such as cancer, or liver disease, but it's also a function of things like being in the car when someone's intoxicated or driving under the influence. Substance use during adolescence also negatively impacts relationships. That's both with friends as well as with family members, and that's both during the teenage years and down the road with lower quality relationships in adulthood. And substance use during the teen years also seems to narrow teen social worlds, such that they increasingly spend time with peers who use substances and spend less time with peers who engage in other behaviors. And there are also high levels of conflict amongst teens who use substances. those consequences are obviously not good. And researchers interested in how substance use starts and escalates have really been trying to pinpoint what are factors that are strongly implicated in adolescent substance use initiation and escalation. And for decades now, there has been growing, robust research pointing to caregivers and their roles in adolescent substance use that I want to highlight before jumping into treatment. So, although teens will never want to admit this, and I've never worked with a teen clinically who was like, oh, yeah, I'm so happy that my parents still have an influence over me. Caregivers are still extremely powerful socializing agents during adolescence. And to convince y'all of this, I just want to note that there are so many correlates, literally dozens of correlates of teens initiating substances, starting to use substances, and the escalation of their use. These include things like genetic risks, peers, personality, neighborhoods. Um, and many of these factors are hard to modify. It's hard to modify someone's genetic risk currently. It's hard to modify neighborhoods or socioeconomic factors. But caregiving is modifiable. We know that we can change it. And there is research showing that these risks that I just mentioned, things like genetic risk, peer risk, personality, neighborhoods, that those risks are less strongly associated with the onset and escalation of substance use in the context of effective parenting and caregiving practices. So caregiving can reduce these risks. Additionally, this is across the board during adolescence. So this is true for substance use, but this is also true for mental health conditions, things like anxiety, depression, ADHD. When caregivers are involved in youth treatment, that is associated with better outcomes. Research has also sought to pinpoint specific caregiving behaviors that can increase and decrease risk for adolescent substance use. And I want to note that there are many, many caregiving behaviors that are associated with increased or decreased risk. I'm just pinpointing some that have the most research across time. So some of the parenting dimensions that have been shown to increase risk for adolescents starting to use, as well as they're increasing their substance use, are things like parental conflict, so the amount of hostility, criticism, tension that exists in a family, caregiver substance use, and that's both levels of use as well as a caregiver having a substance use disorder, and the attitudes caregivers have towards substances. The more favorable caregivers' attitudes are, and that's both explicit, them voicing those attitudes, as well as implicit, so not even really being stated out loud, those have been implicated in adolescents being at greater risk for using substances. The other risk factor that's gaining increased attention are provisions of substance use. And just to say this in plain language, I don't know if any of you growing up, your parents ever let you had a sip or taste of alcohol, but there is increasing evidence across multiple independent samples that after you control for everything under the sun, you control for temperament, you control for parenting behaviors, psychopathology, neighborhood characteristics, that sipping and tasting alcohol in childhood is down the road in late adolescence, emerging adulthood, associated with increased levels of use, increased consequences of use. So even those small behaviors like parents allowing their child to get access or have a sip of substances is associated with increased use behaviors. There are also, fortunately, many caregiving practices that decrease risk for adolescent substance use. These include a high quality relationship between a parent and a child, consistent monitoring. So these are rules and standards that parents have in terms of knowing where their child is and what they're doing. Parents who have rules about their child's substance use is associated with their child being less likely to initiate and escalate their use, and implementing consistent discipline for when their child does not follow said rules. And also parenting behaviors such as being more supportive, that's showing warmth and love and praise, and being involved in your child's life. Playing games, watching them play sports, even things as simple as having dinner together have also been shown to be protective from adolescents starting to use and increasing their use across time. Whenever I give talks about parenting behaviors in relation to adolescent substance use, something that universally comes up is well, what do you do about parents who use substances or parents with substance use disorders? And what I want to note is there is absolutely, as I mentioned, a positive association between caregiver substance use and an adolescent substance use. However, and this is what I always like to note, there is evidence that amongst caregivers who use substances or have a substance use disorder or a lifetime history of a substance use disorder, if they are supportive, they monitor their child, or they have strong family bonds, this has been shown to significantly weaken or remove the association between caregiver substance use and adolescent substance use. So what this suggests is that amongst parents who have a history of use and parents who have never used, parenting practices such as being supportive, monitoring, and having good bonds can really reduce the risk of intergenerational transmission of substance use and just decrease adolescents' risk of using substances in general. Another thing that I always like to note is I never want to talk about caregiving practices and come across that this is blaming caregivers or caregivers are solely at fault. And I always like to give an example of how this is true. So yes, family conflict is associated with increased risk for adolescent substance use. But adolescent substance use is also associated with increased risk for family conflict, which increases risk for adolescent substance use, which increases risk for family conflict. These things reciprocally influence each other across time. And the reason this matters, and I'm going to talk much more about this later, is that parenting, caregiving occurs in a relational context, and that's never independent of the child. Some children are more easy, some are more difficult. Thomas and Chess wrote about this in the late 1970s. So parenting and caregiving practices occur in a relational context. So it's a dynamic that exists between people that's really important. So hopefully I've done a somewhat decent job at convincing you that parents matter during the adolescent years with respect to substance use. So now I want to talk about caregiver involvement in treatment and what that looks like. So meta-analytic studies, these are studies that have combined multiple independent randomized clinical trials, and they analyze all that data simultaneously. They suggest that of all the different treatments for adolescent substance use, family-based treatments seem to be associated with the best outcomes. Again, as I mentioned earlier, this is consistent with broader research showing that caregiver involvement in adolescent substance use and mental health treatment is associated with better outcomes. So that's awesome. And as someone who does caregiver involved research, I'm like, great, this is a really wonderful case as to why parents are so important. But when you look at real world clinical practice, and when I say real world, I mean outside of like the setting that I'm in a university or a clinical trial in a university, in real clinics in the real world, caregivers are rarely involved in adolescent substance use treatment. And there are a lot of really legitimate reasons for this. There are issues with respect to having the infrastructure and training to include parents. In our state of Massachusetts, kids can consent to treatment at very, very early ages, particularly for substance use. And why would a child ever say, you know who I really want in treatment? My parents. So there are also structural barriers that make this difficult. So despite the fact, and this is where we're at, despite knowing that caregiver involvement is associated with better outcomes, they're not often involved in real world practice. And when I'm talking today about practices that y'all can incorporate, I'm going to be talking about family-involved practices from a core elements approach. And I'll briefly provide the rationale for a core elements approach, which is that there are many wonderful evidence-based treatments for family therapy. There are things like functional family therapy, multidimensional family therapy, brief strategic family therapy. And a question people have been asking is, what if we can identify across these different manualized treatments what's similar amongst them, their key ingredients, their key components, and train community providers just in those core components? Would that make it easier for these interventions to seep out and be adopted in the real world? And I'll say this work has primarily been led by Dr. Aaron Hogue and colleagues at the Partnership to End Addiction. I want to give a plug out for them. And they've shown that training community providers and core elements approaches are effective. So when I'm talking to y'all about family-based practices today, I'm not rooted in one of these evidence-based treatments, but I'm really going to be talking about what's similar across these multiple evidence-based family-involved treatments. So in taking this core elements approach, uh, there are some ingredients that seem to be uniform or pop up consistently across family-based treatments for adolescent substance use. And I want to go over each of these before I jump into some applied practices for what they look like. The first is something called relational reframing. And what relational reframing refers to is defining adolescent substance use problems and mental health problems as an issue of relationships, not that of the child or that of the caregiver, but of the relationships that exist between them. And I'll speak more about what that exactly looks like. Other core elements of family therapy are practices that engage the youth. Teens want autonomy. They want independence. They want to make their own decisions, even if developmentally they're not making the best decisions for themselves. So empowering youth during treatment and empowering them to see family therapy as a solution for their problems seems to be really important in these family-based treatments. There's also interactional change. That's observing families interacting with each other and directly intervening in those interactions between a teen and their caregiving system to promote more effective relationships, and having a relational emphasis. That's asking questions about the whole family, including the whole family, administering interventions targeting the family system as a whole. These seem to be the core elements that I'm going to be talking about today. And I just want to clarify again, I'm not rooted in one specific type of family treatment, but talking again about what's similar between them. So to do this, I'm going to use a clinical case example from my clinical work or working with teens with substance use disorders. And I just want to note, this is an example integrating a few cases just to respect the confidentiality of the teens who I've worked with. So for this case example, here is Rick. He was a 17-year-old biracial cisgender male who I saw. He was presenting to treatment for depression and cannabis use. And when giving clinical case examples and talking about these, I always like to give people a little bit of a flavor of like, what was this person actually like to work with? So some other really important information to give you a flavor of Rick. His caregiver was divorced when he was 5. His biological father, who was involved in treatment, had an opioid use disorder, was currently in recovery, and his biological mother she had a pretty extensive family history of substance use disorders as well. Rick received extensive bullying from elementary school through high school when I saw him. And his depression was at the point where his self-care was really low. He was having a hard time showering. He was having a hard time just like picking up. There was like old food, days, months old food in his room. And there was a lot of conflict in his family around his hygiene, around arguments between each other, about his cannabis use. So things were not going well for Rick and his family. And when talking about engaging a family like Rick in treatment, I just want to note that family engagement, and this is based off of evidence-based practices, really should occur for including Rick's parents in treatment, should occur actually before the first session. Engaging families for all the reasons I mentioned is hard, but some evidence-based practices that can facilitate family involvement in treatment starts actually with the very first outreach attempt. So these include practices such as flexible scheduling to accommodate caregivers or other concerned significant others, making sure it works around their work schedules, calling caregivers to provide a rationale for involvement. I'm not sure how many of you have worked with teens, but my experience working with teens is that the analogy that I give is parents often expect like treatment to kind of work like dry cleaning. You take your clothes to the dry cleaner, they have stains everywhere, you bring them back, they look fresh and nice and new. And that's kind of what parents are expecting. You drop your kids off at therapy, the therapist does their magic, they come back, poof, they're as good as new. And that's not how treatment works. But like we have to make a case when talking to a parent before treatment even starts about why their involvement in therapy matters. We have to make the case for them and let them know that not only is caregiver involvement an important part of treatment, it's a best practice and associated with improved outcomes for your child and will also make life easier for yourself. There are other things that you can do, such as scheduling home visits. Just again, these just reflect, though, that engaging families in treatment should start as early as possible. Another thing not noted here is if your clinic or the environment you work in can set an expectation that families are expected to be in treatment, and you can note that ahead of time, that's another practice that can make it easier to include families and have caregivers actively involved in treatment for cases like Rick. So what I'm going to do now is talk a little bit about relational reframing, engaging both Rick and Rick's mom in treatment. And I'll say Rick's mom was the predominant family member involved in treatment. And I'll use this as an example, but this is again rooted in family-based practices to motivate teens and engage them in treatment. And this typically happens after the assessment process in the first session or two, depending on the time. So when working with families, the the question that many families have is, okay, Sam, who's to blame? Rick wants to know, am I at fault? Rick's mom wants to know, am I at fault? And they really are trying to leverage me to think it's the other person who's to blame. And my goal in the first session when working and engaging with families is to get out of that type of conversation and to actually say, not only do I not think Rick that you're the problem, or Rick's mom that you're the problem, but I actually think the issue is the space that exists between you, the relationships that exist between you. And that is going to be the target of treatment, the relationships that exist between you, Rick, and Rick's mom to make things better. Right? So we're getting out of the blame game early on. And I'm going to talk about how do we actually get to this point where you can make the case, make the pitch that relationships should be a fundamental focus of caregiver involved treatment. So, right, this is the end goal. So here, what I'm going to go over are concrete steps in session that I'm taking to engage and motivate caregivers to participate in treatment and to have Rick participate in treatment and be willing to work on his family relationships. So the first, and again, this is in service of respecting the autonomy and the strengths of both a teen and their parents. The first part of this process is exploring strengths. So I explicitly asked Rick and Rick's mom about different areas of their life to be able to pinpoint this. So some strengths of Rick included things like he was athletic, kind towards his siblings. He and his mom described actually a really wonderful, close relationship growing up, and he really cares about his future and his well-being. Mom was clearly so dedicated. She would do anything for her kids and was hardworking. Also, when talking about strengths, in addition to these individual strengths, it's nice to also recognize broader family factors that can be conceptualized as strengths. So one is the family had a very strong cultural identity. They wouldn't describe themselves as religious, but their cultural identity was important and a large source of social support for them. And also to support her family, which was a strength, mom also worked very long hours, which was important to know both as a strength of hers and also she was really tired. She didn't have a ton of gas left in her gas tank because she was expending so much effort on her family. After noting the strengths of the family, the next set of questions that you can ask, and I'll talk strategically about why you can do this, is amplify the frustration with the current situation in a family. So topics that you can discuss and that I discussed with Rick and his family were they were all really concerned about his symptoms. They were concerned about his hygiene. Rick valued school and his school was really on the decline. So both he and his parents, there was no argument over that. Everyone agreed that he wasn't functioning in a way like that was good for him or anybody else. Everyone agreed that they were unhappy with the current relationships in their family, and they remembered old days when the relationships were much better. They all acknowledged that treatment was helpful for Rick and his family in the past. And they all also recognized that Rick was the target of long-standing bullying and harassment, and that had a significant negative impact on him. And the reason why in this first session, I am asking about things like symptoms, relational impact, past treatment, experiences of racism, discrimination, examples of injustice, is these are all things that both Rick and his family agreed upon. This wasn't a source of argument or contention, but rather something that was motivating for all of them. They all recognized these things, were in agreement about these things, and wanted to change things like their relationships and their symptoms. So this is a way of actually getting them to join and unify early on in the treatment process. And then next, and most family-involved treatments have a version of this question. And when I was learning family-based treatments, this question had the greatest impact on my clinical practice, is asking some version of this question to Rick and eventually to Rick's mom at the end of the first session. The question to Rick is something like this. Rick, why did you decide to smoke weed instead of going to your parents for help? And what Rick said in session was he was so worried about getting yelled at that he was like, I might as well just go and smoke weed. And that seems a little counterintuitive. If you were worried about getting yelled at, why don't you just go talk to your parents? But when talking through this with Rick, what Rick was saying is he just feels that he is constantly getting yelled at, accused of doing wrongdoing. He can't do anything right. So it's much easier for him to go and use cannabis than risk going to his parents where his emotional well-being can be worse. And a caregiver sitting in the room, hearing that their child doesn't feel comfortable coming to them for help, brings up a lot of emotions and usually makes caregivers very, very upset to hear this because they want to be a source of support and love for their child. This question really brings up themes of attachment and issues of attachment, which are often a core focus of caregiver-involved treatments. But again, to ensure that this is not a blame game. And the next question, the follow-up to this, is then asking Rick's mom, when you felt strong feelings growing up, what did your parents do? And Rick's mom said, when she tried to talk about her parents or talk to her parents about her emotions or was going through hard times, they yelled at her. They dismissed her. They did not give her a space to talk about her feelings. And this is really important because it highlights to Rick that Rick's mom actually never had that experience either. And she never had the opportunity to learn how to talk about feelings and understand difficult situations because she actually went through the same thing that he went through. And then in gathering this information in the initial session, and again, this doesn't have to be just one session. You can do this over 1 or 2 or 3 sessions. I've gained information about the strengths of Rick and his mom, their joint frustrations, and attachment issues in the family when it comes to learning how to talk about, relate, and experience emotions in a healthy manner with each other. And what that in combination allows you to do is then make what I call the pitch. And the pitch is something like this, and you'll work it for your own teens that you see. But it's, Rick, you are a really impressive young man. You are athletic, you care about school, you care about your family. And mom, you also are so dedicated to your family and are willing to do everything in your power to make sure your family is okay. And both of you are really frustrated with the current situation. You're unhappy about your relationships. You're unhappy about how Rick is doing. And you've both expressed you want to learn how to turn to each other and be there for each other, to support each other when you're going through hard times. And right now, Rick, to support you through your depression and your cannabis use. And I'm wondering, with that in mind, can we work together on finding ways for you to more effectively talk and work through this with each other and end this pattern that seems to exist in your family across generations of wanting to turn to your parents for help, but struggling to know how to do so? And in this pitch, which is the relational part of the relational reframe, I have made the case for treatment and the fundamental focus of treatment being the relationship that exists between Rick and Rick's mom. I'm trying to make the motivational case for the involvement in treatment, the focus of treatment again on the relationship. So let's say that pitch works. They agree, yes, we need to focus on our relationship. This sounds really good. Now what? So I'm going to talk about practical skills for involving caregivers in treatment, because this is a source of anxiety for many, many providers. Like, okay, if it's important to include caregivers, how do I actually go about doing that? So effective conversations that avoid conflict, allow skill use, and improve relationship dynamics in therapy require high levels of structure. Why is this the case? If families are coming into session and they are fighting a lot and you just let them go, they are going to fight a lot. You have to have that structure and control in session so those dynamics which you're trying to work on don't unfold in the therapy room. And what I'm going to talk about is a concrete strategy of structuring conversations that you can use to impose that structure and to try to alter relationship dynamics. So I'm going to walk you through, and probably many of you are familiar with this. This has different terms across different family therapies and even couples therapies, but this is how it works. So in step one interaction partner has the floor. So here, this is Rick. And ideally, you want the topic of whatever it is that Rick and Rick's mom decide to talk about to be decided by them. Ideally, early on in treatment, it can be decided on by the teen. The reason that's the case is, again, you're being mindful of the developmental needs of teens, one of which is autonomy. So just giving the teen even the feeling of choice can make them more engaged in treatment. So the way that it works is Rick has the floor, and his job is to talk about a situation that's going on and do that very briefly. So here he said, I was mad when you came into my room unannounced and accused me of smoking last night. That's step one, a short utterance of what the situation is and what's going on. Then in step two, the other interaction partner must repeat back what was said. And here, this is mom. No commentary, no additional thoughts, no adding to it. Their job is to literally repeat back just what was said. So if mom were to do this well, she would say, you were mad when I came into your room yesterday and said, I thought you were smoking earlier yesterday. Next, mom has to ask the question, did I get that right? And then Rick responds yes or no. If Rick responds yes, then we're going to go on to the next step where he's going to continue to kind of speak his mind and talk about what was bothering him. If it's no, then Rick will repeat what he said. Mom will have to summarize that back and ask if she got that right until Rick confirms that mom has heard what he has said. So let's say mom gets that right. Then Rick continues to speak in, again, small segments that it's possible for the other person to remember what was said. Yeah, I feel like you don't respect me or my space when you attack me like that. Then mom again repeats, you feel attacked and disrespected when I came in your room yesterday. Did I get that right? And this pattern continues until Rick is done talking. He has the floor. He said everything that he's wanted to say. Then Rick's mom has the opportunity to take the floor, and after everything that she says, Rick has to repeat it back and ask, did I get that right? This pattern continues of conversing until the conversation is over or your session is over. So I just want to emphasize some of the reasons and not reasons of this activity. So the goal of this activity is to alter interpersonal dynamics. When I do this in session, families are like, this is weird. I don't like this. This feels robotic. And I'm like, nailed it. That is exactly the point. We are trying to do something different that takes you out of your pattern. And that's the exact reason why this should feel so different and robotic to you. And it'll be more natural with time. but we are trying to alter interpersonal dynamics, getting them out of a situation where their conversations quickly lead to conflict. We're promoting turn taking by having one person take the floor. We're promoting active listening by having one person repeat back what was said and make sure they got that right. And by slowing things down, and oftentimes, if you have ever gotten in a fight in your life, you realize that you're kind of putting points quickly back and forth, emotions get heightened. It really becomes hard to really hear what the other person is saying. By slowing things down, families can start to develop a better emotional understanding. And I'll say, as this technique develops over the course of therapy, you won't only ask someone to repeat back what they said, but I might start to ask questions to Rick's mom like this. Um, so Rick said that, but what feeling do you think he's trying to communicate? What emotion is this bringing up for him? So by slowing things down, it also allows families the opportunity to start to better understand not only what they say, but how they're feeling and the feelings that underlie some of their statements. And this also serves as a method, once families establish enough practice around this, to start to talk and use this activity to talk about difficult topics outside of session. I want to be really clear. The goal of this activity is not problem solving. And many a times I will do this activity with the family for an entire hour-long session and nothing is solved. And they go, "Hey, Sam, nothing is solved." And I go, "I know. Isn't that amazing?" And they go, "What do you mean?" And then I go, "Y'all just talked about an issue together for 45 minutes, an hour, and you heard each other out. That's amazing. That is so different for y'all." And while problem solving often does happen over the course of these sessions, it's not the goal. Having the ability to talk and hear what each other say is a necessary first ingredient before problem solving can come in. I can introduce problem solving skills, that's good, and I often do. But if you can't talk to each other and listen to each other, problem solving skills aren't going to work. So this is like a necessary foundation in order to be able to move on to some later skills. So with that, we've spoken about, with respect to caregiver involvement, making that pitch, that relational reframe, motivating the teen, and structuring family conversations to alter the dynamics. I want to end today on some broader thoughts about, I think, where we need to go to better understand caregiver involvement in treatment, and then I'm really excited to hear questions that y'all have. So the first thing is we need to do a better job of thinking about caregiver involvement. Historically, when we talk about caregiver involvement, we think about things like session attendance. Maybe we're tracking how much time a caregiver is in session. But there are other really important dimensions that we need to understand that reflect the extent to which a caregiver is involved in treatment. These include things like the reasons caregivers do or do not attend session. This could be feeling blamed by a provider, the therapy isn't in the caregiver's primary language, logistical barriers like transportation. It's also important for us to understand the therapeutic relationship and alliance between a caregiver and a provider to test whether a caregiver and a provider align in their goals for the teen, and also to get an understanding of maybe a caregiver can't show up every week to treatment, but they're still talking to their child about the skills they're learning in therapy. They're helping their child implement those skills. Maybe they're playing a very active role in helping their child be compliant with their medication. And the reason why I bring these points up is in order for us to understand how to better involve parents in treatment, we have to measure these factors. Measuring these factors will give us a better understanding of not only overall caregiver involvement, but when we're working with specific families, with specific teens, what are the barriers, tools, facilitators we have for a specific family that might help us engage them? If it's logistical barriers in transportation, there are things that we can do to facilitate that. If there are discrepancies in goal agreement, that's something that needs to be discussed. But if we don't measure and capture this information, it's going to be really hard for us to do a better job of engaging and involving caregivers in treatment. Another thing is, it has never been harder to be a parent. When we talk about the adolescent mental health crisis in our country, we often like to reduce that conversation to smartphones and social media use. But something that gets swept under the rug is the levels of stress amongst parents is the highest it's ever been. One clear example of that is for generations in our country, caregivers were in a better financial situation than their generation before them. That is no longer true. It is really, really hard to be a caregiver. We have to figure out how to make treatments easier. So what we need to do is we need to do a better job of understanding not only core elements, but the core tools and practices that go on during family-based services that seem to have be the biggest drivers of change, because that might then inform how can we simplify these treatments as much as possible just to the ingredients that work. And if they're as simplified as possible, that might make it easier for caregivers to attend, and it might make it easier for providers to implement these interventions. And I'll say this is work that is near and dear to my heart that I work on in trying to understand what's going on in treatments in the real world and what are parents doing day to day that really seems to drive change so we can make interventions a little bit simpler. And we also have to continue to make it easier for caregivers to be involved in treatment. This is flexibility in how our treatments are designed, where they're designed, what involvement actually looks like. We have to think holistically about this. Again, because, and I just want to emphasize this, we know that when caregivers are involved in treatment, that is associated with better outcomes. So multiple approaches that we can take to make it easier for caregivers to be involved, we have to think through and support those efforts. So with that, I just want to thank y'all for your time. I'm putting my contact information here. I'm also putting my lab's Instagram here. The reason I'm putting it is we often do like parenting campaigns. We did a recent 14-day push on caregiving practices that are associated with reductions in adolescent substance use. So happy for you just to see that content. And then I have one more slide for y'all that I think Dr. Bergman's going to talk about.
Yes, thank you, Dr. Meisel. Before the Q&A, I just want to let everybody know that we would love your feedback. It's important and provides support for this type of work to continue. Scan this QR code to access the feedback survey. We're also going to post a link to the survey in the chat so that there it is. So you can use the QR code or or the survey there. It says, please share Instagram again. Not sure what that means. So with that, let's open it up for some Q&A. There were a few questions, Dr. Meisel. We'll start with the first set, which is from earlier in the talk. Folks wondered, they said, in other countries, they have looser attitudes towards children drinking and allowing kids to drink at earlier ages. How do you square that with the research that you're talking about where sipping and allowing access to alcohol earlier tends to lead to more drinking later?
That is a really important question. And there is actually data to suggest, and I think one of the ideas is that cultures that are more accepting of drinking and where it's more ingrained in the culture and happens at earlier ages, that promotes kind of a greater understanding and learning on the part of the teen that leads to lower consequences. When you look at the data, that's actually not true. Those cultures have elevated risks of teen binge drinking, problems associated with use, consequences, development of substance use disorders. So those permissive parenting practices don't actually seem to be associated with better outcomes. So they're still, bottom line, they're still risky.
Got it. Okay. And there was another question about how to have conversations with parents that take into consideration both suggesting that kids abstain or helping kids abstain from a prevention perspective, but then also taking harm reduction into account if a kid does decide to use. So it's sort of, I'll say the question more clearly. How do you recommend parents set clear expectations around abstaining from substance use while still keeping communication open about safety and harm reduction if their child does decide to use.
Mhm. That is an important point, and it's an imperfect analogy. But what I often talk about with parents, and I also do work in the prevention space, is that like imagine that I went up to a parent and I was like, um, our goal is for your child to never be depressed. And if they are depressed, then let's never give them treatment. That would be crazy. I would probably get ethical concerns. My license would be removed. But for some reason in the substance use space, right, it's like we try to prevent use. But then if a teen does engage in use, it's this huge thing, a huge fight. So the emphasis and discussion is it's going to be way harder for you to be a good parent, to be an effective parent, if your child isn't comfortable talking to you about when they make mistakes or when they do things like using substances. And what do we know? One of the most protective factors from escalations in use, problematic use later in life, is child disclosure. So that's the actual act of a teen discussing with their parents what they're doing. So in framing prevention programming, what you want to do is all the relational components, a strong bond, effective communication is there. You also want to explicitly talk about the harms and dangers of adolescent substance use, particularly the things that are unique about using during the teenage years, things like concerns on altered brain development of these processes that are really important for lifelong success. And you also want the teen to know that a parent is always going to be there for them, wants to be there for them, will support them. So if they engage in use, or if they engage in any other risk-taking behavior, or they end up at a party and stuff is going on that they're not comfortable with, that they're willing, comfortable, and able to reach out to their parents.
And then along those lines, I mean, you're speaking to this a little bit.
Yeah.
There's a question in the chat that asks how do you navigate treatment if when the parent and the teen have different goals? So the teen wants to come in and reduce their use, and the parent wants their kid to abstain and has that sort of concrete goal. What strategies do you use to approach that?
The the strategy that I often like to take, and then again, this is really rooted in kind of common processes, process-based therapies, is the concept of workability. And what we will discuss between a teen and their parents is this working or not? So, like, what is the main goal of treatment? And when we talk about substance use treatment, we often talk about the main focus being reductions of use, and that is sometimes the least appealing motivation for a teen in the world, because they actually often don't view their use as a problem at all. The thing that really is motivating, and this is true of broader discussions about recovery not solely being a function of reductions in use, but the broader context and elements of someone's life, the things that hook a teen are improvements in school, better peer relationships, their mental health getting better, their relationship with their parents getting better. So going back to that workability idea is, we can try and see if you're able to reduce your use and those other areas of your life get better, you're functioning well, your relationships are better. We can see if that's working for you. Wonderful. And if not, then we're going to have to consider that goal, because our end goal is for you to thrive and live a meaningful, fulfilling life. And substance use is a part of that. So it's almost like it's a hypothesis, it's an idea. Let's see what happens. And setting agreement that the goal use is a part of the goal, but the major goal is actually just improved functioning and quality of life and value for the teen and also the parents, and putting that at the forefront.
Thanks. Yeah. And then there was another question sort of, so it's along these lines, a lot of questions along these
Yeah.
same lines. If a parent wants to check their kid's substance use through drug testing, other kinds of monitoring, how do you tend to handle that?
So what I will say, and I think this is one of the reasons why and we meaning researchers, have to get a little bit better at what we're doing, is I mentioned that monitoring is a parenting practice that is associated with better outcomes for substance use. I have yet to clinically be in a situation where a parent is like, I want to monitor what you're doing. And the teen is like, oh, thank you, parent, so much. That's so kind of you. I'm so glad that you're going to want to know more about my life. Um, that doesn't happen. And that's why the relational context is so important and being able to have conversations between a parent and a child around these decisions. So it feels like a joint decision. What are the parameters for that? When does this happen? What say, if any, does the teen have? Again, if these monitoring practices, which are overall maybe net good, are not done in a developmentally appropriate way, respecting the autonomy of the child, making it feel like a discussion between the parent and child, even if in the end the parent's like, I'm still going to do this. But if that pretext isn't there, there isn't that conversation and understanding and the parent making the case as to why this is important, then it's probably not going to do well. In terms of research, we need to have a better understanding of kind of these shorter term decisions and the impact they have on long term functioning. And it's also like how that case is made and making it relationally oriented that matters. If a parent's like, I'm going to drug test you because you're doing the wrong things and you keep messing up, probably going to be less effective than saying, like, the number one thing that I care about is your safety. And like, even if you're mad at me and you hate my guts, but you know that I'm doing this because I love you and want to make sure that you're safe. Those have very, very different feels. So really focusing on how those discussions are done, that they're done in a context of building the quality of the relationship between a teen and child, even when they don't agree, because most of the time a teen and their parents don't agree. Those can be ways of making decisions like drug testing and styles of drug testing more effective.
Great. And then one final question. If a caregiver is worried about the types of friends their teen is hanging out with, how do you tend to handle that?
Yeah, so that is a good question, and an area for additional research. I will say there is some older work demonstrating that higher quality relationships between a parent and a child seems to provide parents with a little bit more leverage in being protective from those risks in the peer context. Um, but this is something that's so hard because it reflects the need to study adolescent substance use from a developmental context. Asking a teen to change their friends or not hang out with people anymore is so hard because that is one of the core tasks during the teen years. So how parents go about doing that, again, is really rooted in how you go about talking about that, extracting information from the teen. What do you think about this? What are your concerns about your friends? What are the positive things about your friends? Supporting their autonomy, having it be a conversation. How are we going to know if your friends are helping you live a life that you want to live, or maybe you're moving in a direction that you don't feel great about? What can we do about this as a family to monitor this? That's one thing. And I'll also say, even if there are concerns about one friend group and you're having these open conversations, it's never a downside to also just get some more positive peer influences and thinking about other domains or areas where a parent can hook their child into social activities where they might be with pro-social peers, whether that's extracurricular activities at school, religious organizations, mentors. Those are their other options that are at a parent's disposal, a caregiver's disposal.
Great, thank you. Well, we are at time, and I just want to say too, there were a bunch of comments in the chat about how great the presentation was, and I concur. Dr. Meisel, thank you so much for a fantastic presentation, um, and thank you everybody for being here. And we will see you next time. Have a great rest of your day.